Okay, class. In this unit, we'll get into blood pressure and kind of like this sort of cartoon. Blood pressure is definitely not something that you want to have a particularly high score in, right? So some epidemiology. So hypertension is the leading risk factor for cardiovascular disease mortality worldwide. It's leading cause of cardiovascular disease worldwide. And the problem is that it's asymptomatic, even at extremes. And we'll get into more of that later on in your cardiopulmonary coursework. But yeah, it's a big problem. So even patients with emergent hypertension, right, or hypertensive crisis, like they may have no symptoms. And only about 50% of people, even if they're medicated, are compliant or at their goal blood pressure. So in many respects, hypertension is the silent killer for our Metal Gear Solid fans out there, Solid Snake. Again, just breaking things down by geographical distribution so that we see, differences in locations, right? But if we overlay this map, it almost looks identical to what we see for physical inactivity and obesity. So, we look at how those, diabetes as well, we see how those things are kind of dynamically linked. And that's a big problem across the country, right? And if we look at certain age breakdowns, right, obviously this gets higher, the prevalence in hypertension goes up as we age. There are some normal age-related changes to the blood, to the vasculature, that give older patients a higher prevalence or higher likelihood of developing hypertension. Changes in collagen amount and structure, reduction in elastase in the arteries. So a lot of different things change as we age, but obviously, as we talked about before in previous lectures, that the cardiometabolic disease, obesity, diabetes, smoking, other issues are major problems here. Now, the thing that really stands out from this graph, and I want to stress this, and you'll hear me talk about this often throughout courses that you take with me, that we need to change this narrative that cardiovascular issues, hypertension, is only an issue that affects old men. It affects old women. And I'll say this again, and you'll hear me say this repeatedly, that because it's true, the leading cause of mortality in women is cardiovascular disease. Obviously, breast cancer, other conditions are front and center. Breast cancer, I believe, is number 2, and it's a tragic disease. But we often don't give enough attention, or as much attention, really, to the burden of cardiovascular disease in women. And this, I think, graph here demonstrates this. This is, for hypertension, that while obviously in younger age groups, right, people below 65 in particular, that we see higher prevalences in male. We think estrogen is a protective hormone, so we see a lower prevalence in women. But after about age 55, when we see menopause kick in for most women, the levels of estrogen they produce are much less or absent. It levels off. And in fact, in older women, they have a higher prevalence. Now, some of that may be influenced by survivorship bias, but again, like blood pressure is a major concern in women too. Let's just make sure we're screening and taking this to heart, no pun intended. Now, the other thing that I kind of like to highlight here is when we think about the populations you're going to be treating as a PT, the overwhelming majority of patients, and I know this because we've done research on this and we published it, that even an outpatient, you're going to be working with people over the age of 46. And if you look at when we move into that next, I guess as a quintile, or not even a quintile, or this next grouping, we start seeing this rate, right, this prevalence almost kind of go up in an exponential fashion. So in PT practice, again, the older, we tend to work with older populations, 46 years of age or older. And again, we have data that supports this. We published it in PTJ. We'll share some of those findings in a bit. And then again, if we look at the intersection of physical inactivity, obesity, some of the conditions that we see as a clinician, that this is something we need to be aware of as a PT, that, I would even say it would be rare for a PT to work with someone in the clinic who doesn't have some sort of cardiometabolic disease, notably hypertension. Now, why this is so concerning, this prevalence, we talk about this widespread, it's an issue, is that it's not even a guarantee that everyone's aware of it, receiving treatment, or even controlled. Awareness across the population is at about 80%. So these are people who are aware of their diagnosis of having hypertension. So 80%, are aware. And then only 70% receive treatment, right? That's also a concern because every 10% improvement in treatment could result in reduction of 14,000 deaths. We know this, like it's been well established. And again, these are people, still just people who are even aware, right? And there's 20% that don't even get diagnosed. And that's likely due to the asymptomatic nature of hypertension. What's most concerning, and this has been data that's been consistently reported, and we really actually have made some headways, but it's still been a bit of a concern, is controlled hypertension. It's a coin flip. So even if a patient comes to your clinic and says, well, I have hypertension, I take medications, you can't rely on the fact that they take a medication or that it's in their chart, because it's not even a guarantee that they're going to be at their goal blood pressure, right? And they may not even have symptoms either if it's super exaggerated. So just something to be aware of. It's a coin flip that a patient is even at their goal blood pressure. So, and some of that has to do with patients stopping taking their medications. You'll learn more about that later on. But again, like, you cannot rely on just a patient history. You cannot rely on the fact that they're on a medication to say that they're clear or their blood pressure is normal, because it's a coin flip, even if they're controlled. And again, we've done better at screening for hypertension or controlling hypertension, but it still remains a bit of a problem. So, and really in the past 10 years, it's hovered around about 50%. So it's a coin flip. Now, blood pressure screening, right? There's a consensus on the importance of detection and treatment. Again, every 10% improvement in treatment could result in a reduction in 14,000 deaths. The overwhelming majority of Americans, and this is data from the NIH, but 90% of Americans of all Americans, really, and 90% of people with hypertension have a usual source of healthcare and insurance. Like, so you can go, these patients have regular access to care. So we think improving screening may require bringing in more clinicians to look at this, to assess this, to screen for it, other than just your typical healthcare clinics, your physician's office. So this could include PTs. Now, if you look at the data, we don't typically do too well on this. This is some data from Ethel Fries, published in 2002, looking at CIs and how often they screened. And yeah, only 6% of their survey of 387 respondents found that they used, people screen heart rate, and 4.4% for blood pressure. And if you look at my data, which we published in PTJ, and we included blood pressure and heart rate, and only 15% or so screened routinely, and then about even for those who never screen, right? So a bit of a concern here. And again, we look at why people didn't. A lot of it goes back to their perception of how important it is, and then lack of time, clinic policy, despite the fact that it is absolutely important for your population, because you are going to be screening for it. And then it doesn't really take that much time to screen. And interesting enough, we found that most people have equipment, like it's not a problem. And most people felt that they were competent with it, and how to actually measure. So as we get into assessment, and learning how to do these things, and when you start going on the clinic, you may encounter this situation where people aren't screening. And I think things are changing now with our Vitals Are Vitals campaign, and people are taking this to heart, more seriously. But this is a big problem in our profession, screening for cardiovascular disease, blood pressure and heart rate at minimum. So next we'll get into classifications. So looking at what is a normal blood pressure. So this was a bit of an update, right? So this came in about 2017. The American Heart Association, American College of Cardiology updated their guidelines. Normal blood pressure is still anything from 100 to 120. It's interesting because every time you say someone, ask them what their blood pressure is, everyone reflexively says 120/80, but that's actually just the borderline of normal. So it's 100 to 120 systolic, diastolic 60 to 80 is normal. And then mean arterial pressure ranges between 70 to 105, 110, give or take. The way we calculate mean arterial pressure is you do 2 times diastolic plus systolic over a third, remembering that you spend 2/3 of your time during a cardiac cycle in diastole. So that's why we use 2 diastolic values plus just 1 systolic value to create our mean blood pressure. So that's a way to assess it. Typically, we don't get mean pressure is great if someone's got lower or higher pressures because it can give us an indication whether or not they're at a level sufficient for perfusion, and that's really when we start seeing MAP go below 60. But generally, most people focus on these values. So big thing that changed with these guidelines were we shifted the criteria for hypertension up. So we have normal, right? That did not change. Now there is no such thing really as pre-hypertension. We're just calling it elevated, which is essentially the same thing but different terms. And now that's anyone between 120 to 129 and still less than 80 diastolic. Hypertension stage 1 would be now 130 over 139 or 80 to 89. Now this used to be, above 140 or over 90, but we moved that up because we're learning that even patients with blood pressures above really 125, if it stays chronically elevated, it's predictive of adverse events. So we shift this up to get patients managed better, ideally with an emphasis on non-pharmacological therapy, exercise, diet, sleep, stress management, and patients are high risk, obviously medication. And then now stage 2, which had been previously stage 1, 140 or higher systolic or 90 or higher diastolic, that is now stage 2. And then anything above 180 systolic or 120 diastolic would be a hypertensive crisis, and that would be a medical emergency. You'll learn more about that in our cardiopulm course, but just important to know the new guidelines. Now, there are guidelines for pediatric patients. This comes from the clinical practice guideline for a screening of blood pressure in kids. And it's by different age groups. So here it is. It's by percentiles in very young children, or there's just these cutoffs here. And then for kids over the age of 13, normal is still the same as an adult. And then these are our criteria here for stage 1, stage 2 hypertension. It's almost essentially the same as we see in an adult. Pulse pressure is something that you might see as well. So pulse pressure is basically subtracting the diastolic from the systolic. So systolic minus diastolic gives us our pulse pressure. We think this may be a way for us to assess microvascular function, or in some people view as a better way of predicting cardiovascular risk. So if your pulse pressure is really high, meaning that you've got a really high systolic and kind of normal to lower diastolic, it means you go through large fluctuations in pressure and force through the arterial system. That's not particularly great, and we think that could be predictive of cardiovascular mortality. And then lower, right? If our systolic and diastolic are pretty close in value, or a pulse pressure less than 40 millimeters of mercury, that indicates a pulse narrowing, meaning that we may get to a point where our heart, which systolic blood pressure is a reflection in some respects of left ventricular performance, or stroke volume. You can view it almost analogous to this. And diastolic's almost a reflection of our resting pressure and sort of total peripheral resistance. If those values are getting really close to each other, that's going to indicate that maybe we don't have enough pressure, right, to overcome, or we're getting close to not having enough pressure we can generate to overcome resistance to perfuse our organs. So that's not a particularly good sign if those values are super close to each other. Now, hypotension. Now, same exact rules really as bradycardia. Like there is no exact cutoff for concern for hypotension, except when we get below a mean pressure of 60, because you get very concerned for shock. We call cardiogenic shock. We just don't have enough pressure to perfuse your limbs and your organs. But generally, hypotension is systolic blood pressure lower than 90 or 60 diastolic. Now that again, if someone has a blood pressure that's low and they don't have symptoms, then it's not something that we're particularly concerned about. Like again, you always factor multiple data points into the picture, but Again, if their pressures are low but they don't have symptoms, not a major concern. And even some people would say that, you could say blood pressure below 100, but it's between 90 to 100. It's still kind of borderline for blood pressure. But below 90, that's definitely hypotension. So we'll end here. Then we'll get into blood pressure measurement technique.